So thanks very much to the WHO Collaborating Centre and Professor Leung for inviting me to present today. I'd just like to acknowledge that I'm presenting this webinar from the traditional lands of the Gadigal people of the Eora Nation, and I pay my respects to elders past and present. I'd also like to acknowledge my wonderful parents, who you can see here on my screen, who inspire my research. So before I get started with the presentation, I just wanted to briefly give an overview of our research team here at the University of Sydney. We have a team of about 45 people. This includes research staff, students, and professional staff, and they have a variety of backgrounds, but mainly physiotherapy, exercise physiology, and health promotion. And our research focus is on mobility and falls, healthy ageing and disability. And I lead the healthy ageing stream within the research group. So our research group's aim is to reduce the global epidemic of physical inactivity. We conduct research that develops and evaluates the effectiveness and the cost effectiveness of scalable interventions that target increases in physical activity, structured exercise, and sport more broadly. Myself and others from our research team are on the executive committee of the WHO Collaborating Centre for Physical Activity, Nutrition and Obesity, which is led from the University of Sydney. And this is directed by Professors Fong Savan and Coliguri, who you can see here on the screen. So let's get started. So why focus on physical activity in older people? Well, I'm sure that you'd all agree that physical activity is good for our physical and our mental health. And the benefits of physical activity are numerous, with very few negative side effects. And I like to refer to physical activity as a solid investment that reaps rewards now and into our futures. It's certainly essential for promoting healthy aging. It has numerous benefits, as I said, so it reduces the risk of many chronic conditions. It reduces the risk of stroke, of heart disease, of diabetes, of obesity, several cancers such as breast and colon cancer, and reduces the risk of falling in older age. It also promotes many positive health outcomes such as social connection, mental concentration. It improves sleep, it improves muscle strength and function. It makes us happy, it promotes a sense of community, and it's certainly crucial for promoting independence as we get older. So despite the known benefits of physical activity, populations across the globe are increasingly inactive, and we really do need greater efforts to get the world moving. We know that in Australia, around 50% of adults that are aged 65 or over are insufficiently active. We know globally that around 5.3 million deaths per year can be attributed to inactivity. And we know that physical inactivity has similar importance as a modifiable risk factor for chronic disease as obesity and tobacco. And the economic cost of physical inactivity is huge. The importance of physical inactivity is recognised by the WHO. So they released the Global Action Plan on Physical Activity in 2018. And this provides a framework for countries to increase physical activity. So the overall aim is for a reduction in physical inactivity by 2030 of 15%. So the GAPA includes whole of society actions, and it focuses on creating 4 separate policy areas: creating active environments, active people, active societies, and active systems. And what's important about GAPA is that it recognises that to increase physical activity across the population, we do need a systems-based approach. There's no single policy solution that can tackle this complex issue. And it demonstrates that physical inactivity can't be solved by simply targeting individual behaviour. It's about multiple strategies that change the system within which we all live. But my research and that of my team mainly focuses on creating active people. So we develop programs and opportunities that can enhance people's ability to be active. We also have clear guidance from the WHO on the type and amount of physical activity that's important for maximising health and well-being across all age groups. And I'm going to show you the guidelines for the recommendations for older adults. You can see here on the screen. So overall, it's recommended that older adults should undertake physical activity. There's 3 different sections of the guidelines looking at aerobic physical activity, muscle strengthening, and functional balance and strength training. And you can see the amounts and the recommendations here on the screen. There's also an overall recommendation on limiting the amount of time being sedentary and replacing sedentary time with physical activity of any intensity. And overall, what's important about the guidelines is that they also state that every move counts. So even if people can't be reaching or can't attain these levels of physical activity, any amount of increase in physical activity has benefits for health. So they're messages that we do need to be getting to older adults, that these are the levels of activity that are optimal, but any increase in physical activity has benefits. Thinking about falls now. So falls are also a significant and growing global health issue. We know that once people reach the age of 65, around 1 in 3 of them will fall each year, and many people will have multiple falls. Falls prevention is a target for the WHO, which it describes as a significant and global and growing global health issue due to our aging populations. And in 2021, the WHO launched the Step Safely technical package, and this provides concrete recommendations for evidence-based strategies to prevent falls. And this is across all age groups, so not just older adults. So falls are common in older age, but they are preventable. And I'm going to be presenting the research around prevention in a moment. What's important to note is that falls can have devastating consequences in the immediate post-fall time, but also ongoing for much time after a person has had a fall. So a person can have serious injuries as a result of a fall, such as a brain injury or a hip fracture are some of the most serious. And these injuries can lead to ongoing disability. People often lose their confidence after a fall, and this means that they start to reduce their activity levels. This in turn can result in reduced independence. People start to limit their community participation and often develop a fear of falling. And unfortunately, this vicious cycle results in a greater risk of ongoing future falls. So we do need to intervene and prevent the first fall from occurring because of the devastating consequences that falls can have. Falls are linked to admission to residential aged care, so people often don't get back to their pre-fall level of ability. And unfortunately, a lot of falls result in death. So in Australia, we have statistics that show that each day in Australia, 17 older people die as a direct result of a fall. The mechanisms of falls are quite complicated. So a fall, we like to visualize it as a fall occurring when an individual's physiology can't cope with the task that's being undertaken within the environment in which they're undertaking the task. So the risk of a fall changes depending on these factors. We know a lot about risk factors for falls. So there's a lot of research that's identified risk factors. You can see some of them here on the screen. So some of the physical risk factors include reduced balance and strength with age, declining vision, reduced sensation and reaction time. We know that aging impacts on these physical factors, and we also know that other diseases impact, such as Parkinson's disease, stroke, dementia. And there's medications that also impact on these physical factors. Looking at behaviour, we know that a person's behaviour also impacts on their risk of having a fall. So the choice of behaviour and the amount of attention that they're using while they do that behaviour. And so this is impacted by a person's cognition, their insight, how distracted they are, and their risk-taking attitude. And then finally, there's environmental factors that place a person at risk of having trips and slips. So we know a lot about why older people are more likely to fall, but we've also got a lot of evidence now around prevention, and there's a lot of things that we can do to be preventing falls. The evidence is summarised and was put together to form the World Fall Prevention Guidelines, which were released in 2022. And you can see on the screen here the reference. And you can also see the algorithm that's contained within the guidelines, which assists with determining the course of action for an older person, depending on their situation, whether they've had falls in the past month, how frail they are. So this algorithm helps to make decisions about the care of older people in relation to falls. If we look at the summary sort of key points from the guidelines, you can see here on the screen, and just to summarize them, they talk about falls and related injuries as increasingly common and being a critical global challenge. So we need to be preventing falls to stem the ongoing issues that can occur after a fall. Opportunistic case finding is necessary because many older adults have a fall, but they won't present to medical care following that fall. So it's important to be asking the question of older adults, have you had a fall in the past year, or do you feel unsteady on your feet? Multi-domain interventions are important, and this is crucial for tailoring to an individual's risks, certainly for the higher risk people. We also need to think about engaging older individuals' beliefs, their attitudes and priorities about falls. And this is because there's a lot of stigma and guilt attached to falls in older age. So the way we frame the conversations around falls is really important, as well as the content that we deliver. So how to approach conversations about falls requires some thought. And much of the research in fall prevention has been conducted in high income settings. And so we need more research in low resource settings, and we may need to modify the recommendations to meet the needs of lower resourced settings. In terms of the overall recommendations from the guidelines, the recommendations are split into 3 levels depending on a person's risk. So people who are at lower risk, who've had no falls in the past year, it's recommended that they undertake exercise that targets balance and strength. People who are at moderate risk, so 1 to 2 falls, it's recommended they also undertake exercise and also have home and community safety education and other single interventions where needed. So that's things like cataract surgery or a medicines review, depending on the person's risks. And then finally, people at higher risk, those who've had 2 or more falls in the past year, also it's recommended for them to have individualised exercise that targets balance and strength. And they also need to have tailored interventions as indicated, and you can see them listed there. So overall, the main message from these guidelines is that exercise that targets balance and strength is for all older people, regardless of their risk or whether they've had a fall in the past year. A bit more on the types of exercise that's important. So a Cochrane review was published in 2019 that looked at exercise alone for preventing falls in older people living in the community. This was led by my colleague, Kathy Sherrington, here at the Institute for Musculoskeletal Health. We identified a huge amount of evidence, so 108 randomised controlled trials that included over 23,000 participants. And we found that exercise is associated with around a 23% reduction in the rate of falls compared to control, but that not all exercise is equal. So we found that exercise must challenge balance for it to reduce the rate of falls. And what we mean by this is exercise must be conducted in a standing position. There must be movement of the center of mass, narrowing of the bases of support, so bringing the feet closer together or standing on one leg, and minimizing upper limb support. So we really need to see that challenge to the balance for there to be an impact on the rate of falls. And this is really important. We need to be challenging older people when we give them exercise rather than making it too gentle for them, because that's not effective in promoting prevention of falls and other outcomes. Okay, so we've got a lot of evidence around falls, the importance of physical activity, fall prevention, risks, and how to prevent falls and how to promote physical activity. But there is this gap between the evidence and what happens in practice. So we do need greater efforts to implement the evidence into practice. And we want to do this in a scalable and practical way so that we can see an impact on the lives of people in the community. And so my research is very much focused on trying to have this real world impact and to develop programs that can be scaled up and implemented across the population. So what I'd like to do now is just touch on a few of our research studies that we've been doing here. So you can see a summary here of some of our research. We have 3 focus areas with the research with older people. One stream of research looks at community dwellers age 50 plus, and we develop behaviour change programs looking at physical activity and falls in those people. We then have a second stream looking at health professional education and support to promote physical activity and fall prevention. And then we have interventions that target people who are frailer and who are visiting health services such as hospitals and residential aged care settings, and people who've had brain injury is another stream of work that we do. And so what's underlying all of this research is really behaviour change. There's many identified barriers to physical activity behaviour change, particularly for older people. And there's a multitude of frameworks and theories that can help us to think about the factors that influence our behaviour. And so we use this approach of developing interventions that target lasting behaviour change. And we try to make sure that our interventions are scalable and practical for the real world. Some of the techniques that are common to our interventions are the behaviour change techniques you can see here on the screen, things like goal setting, action planning, self-monitoring, and social support. So I'm just going to give you a brief introduction to a few of our current and recent trials. So the first one is the Coaching for Healthy Aging trial. The focus of this trial was around promoting physical activity increases for older people. But there is a risk that when we do that, when we get people to get out and be more active, there's a risk that they're going to be exposed to additional hazards and opportunities to fall. So the question for this trial was, is it important to promote fall prevention alongside physical activity promotion? And that's what this trial really focused on. So the aim was to establish the impact of a physical activity and fall prevention combined program compared with a healthy eating program on the primary outcomes of physical activity and falls. And this was amongst 600 people aged 60 years and over. The intervention that we tested was focused on physical activity and fall prevention. So it involved, first of all, a home visit by a physiotherapist to undertake a fall risk assessment, the quick screen fall risk assessment. There was also then a fall prevention and physical activity plan formulated with the participant. They were given information about being active and staying steady, so a booklet that we developed for the program. They were given the opportunity to use an activity tracker or low-tech pedometer to track their steps and give them feedback about their physical activity. And then they had access to telephone-based health coaching with the research physiotherapist on a fortnightly basis for 6 months, and then a less intensive coaching for the second 6 months of this 12-month intervention. So what we found was a modest increase in physical activity in the intervention group compared to the control group at 6 and 12 months. We did find a lower fall rate in the intervention group compared to the control group, but this wasn't statistically significant. So we were pleased that we were able to increase people's physical activity without also increasing their falls rate. Moving on to the next study, this was the top-up trial. This was a 6-month hybrid type 1 effectiveness implementation trial. The background to it was that there was a Royal Commission into Aged Care here in Australia, which called for better access to physiotherapy services and telehealth in aged care settings. So the aim of this study was to investigate the effectiveness, the value for money, and the acceptability of a physiotherapist-led exercise program, which was delivered via telehealth for older people receiving aged care services. And this was people who were living in residential aged care and also those who were receiving aged care services in their own homes. So it delivered up to 10 Zoom sessions with exercise with a physiotherapist. There was weekly support worker visits. And during these sessions, they also provided education about safe mobility and fall prevention exercise programs and lots of positive reinforcement. There was personalised exercise plans created, and participants had access to the top-up website that included videos of exercise, and also they had printed exercise booklets as well. So the exercise program was based on the Otago exercise program, which is a validated fall prevention program. And they also ensured that the exercises were tailored to the person's mobility goals and tailored to functional activities that were meaningful to the older participants. So overall, top-up was effective in improving mobility, preventing falls, and reducing pain. It was also shown to be cost-effective, and this study really demonstrated that telehealth physiotherapy can be a safe and effective alternative to traditional in-person sessions, and it really filled a gap in access to these types of services, particularly in rural and remote areas of Australia. You can find out more about the top-up program on the website, and there's a Chinese language version of the program coming soon. And then moving on to the final project that I wanted to mention, the Active Women Over 50 project. So this is also a hybrid effectiveness implementation trial. This project focuses on women aged 50 plus. They're often referred to as the sandwich generation, and this is due to their competing priorities, where they're often squashed between the needs of their children and those of their aging parents, while also juggling a career, chronic health conditions, the effects of menopause, and the start of the aging process. And so this often leaves little time for women to think about their own needs and their health and well-being, and also physical activity participation. So we developed this Active Women Over 50 program to address this need. So we're currently testing the program to look at the effectiveness and the cost effectiveness of the program on daily steps at 6 months compared to a waitlist control. And this is amongst 1,000 women recruited throughout the state of New South Wales. We've done a pilot study that you can find at the reference here on the screen if you want to read more. So the Active Women Over 50 program, it's about supporting women to decide what will work best for them and within the constraints of their other responsibilities in life. So there's 4 features to the program. There's a Facebook group, a website that's specifically designed for this demographic with not only information, but options of how to be active and inspiring case study videos that can help to motivate people to be active. There's also 2 sessions of health coaching with a qualified health coach with a background in physiotherapy, and there's access to regular motivational messages through SMS or email. we're currently recruiting for this trial. We've recruited about 820 people so far. We've had lots of positive feedback about the program and lots of interest from people wanting to take part. So it certainly seems like it's filling a gap in need for people in this age group. And then just to finally, one other activity that we're very focused on in our group is, apart from research, is also advocacy, developing guidelines. So we were involved with developing the Australian fall prevention guidelines that were released late last year. We do a lot of advocacy and science communication, trying to get evidence out to the public as well as in academic fields. And we've recently formed the Falls Prevention Alliance Australia. And this is really through frustration of not getting enough policy attention and government buy-in into falls prevention. So we formed this alliance to try and advocate for a mass media campaign, for a national falls strategy in Australia, and for greater investment in exercise programs to prevent falls. So if you're interested, you can find out more at our website. So just to summarize, falls and physical inactivity are major barriers to healthy aging. We know that exercise that challenges balance is the most effective for preventing falls. And older people are diverse in their abilities, their motivations, and their goals. And this makes an individualized approach effective, and often it can be more effective than a one size fits all approach. I'd urge you to open the conversation early about falls and physical activity for healthy aging, and don't wait for a fall to occur before taking action. I'd just like to acknowledge my funding, my research collaborators and participants, and I'd also invite you to get in touch if you'd like to discuss this area further or if you'd like to collaborate. I'm very happy to share protocols from our interventions and explore the possibility of adapting our programs to different contexts or populations. And finally, just to demonstrate that I practice what I preach, here's a photo of me from a trip to beautiful Hong Kong last year, doing a handstand along the waterfront during my morning run. Thanks for listening, and I'm happy to take questions later. Thank you.